So you can see we're talking about autism, the DSM-5. My gosh, has there been just a ton of interest in this. We just had a conference last week, and there's tons of people asking questions about the DSM-5 and what's happening. Obviously, it's not published yet. It's coming out in May. And so the stuff that I'm going to impart today is what I have is the most final draft that I could find, but also to kind of discuss some studies that are out in the field and some other things that might cause some concerns, but also things that we're looking forward to. So, next slide, please. So I put this up here just to give you guys a sense of, like, is this new? So real quick what this quote says. We scrapped these labels about 18 years ago at our place after 2 years of saying we were only going to take the so-called autistic, schizophrenic, psychotic, or symbiotic child. We found that all these labels are just meaningless. We learned more about these kids from working with them on a day-to-day basis. Too many people feel that sticking a label on them means that they now know what the kid needs. I think this is dangerous, misleading, and destructive. Let's go ahead and the question is, how long ago was this statement made? Well, this is actually made at a Leo Kanne colloquium in 1973, and he was even saying almost 20 years before that in 53. They already had these thoughts about, you know, the questions about labels and diagnoses, and especially as it pertains to autism. Go ahead. Another quote, and you guys get to guess how long ago this was. A tendency has arisen to set up a pseudo-diagnostic wastebasket, you can put in there PDD on OS if you want, into which an assortment of heterogeneous conditions were thrown indiscriminately. Such looseness threw all curiosity about diagnostic criteria to the winds as irrelevant impediments on the road to therapy, which was applied to all comers as if their problems were identical. I love this last line. The therapeutic cart was put before the diagnostic horse, and more often than not, the horse was left out altogether. Again, something that I think we still deal with today. The question is, when did they put up this quote? Go ahead and hit through. Well, this was actually made by Leo Kanne himself in 1965. So you can see that these questions that we have as they pertain to the DSM especially, they're not new, especially in how we're dealing with them in the world of autism. Everything seems to come around historically. So I don't know if that's a good thing or a bad thing. Next slide. I put this up here just to give people a sense of, people think, oh gosh, didn't we just have a DSM just a few years ago? This gives you at least a timeline that, yeah, you know what, if you look at like when the actual DSM 1, 2, 3, 4, and 5, not the TR, the updates or the revisions, we're actually pretty much on schedule for the need for the new one. The reason why I put this up here is a lot of people think that one of the driving reasons for APA putting this out is financial. The DSM is actually one of their best sellers, and they make a lot of money off of it. So is there a reason why, from a money or financial standpoint, that the DSM needs to come out? But I don't think that's true. If you look on this slide, we're about due for one, at least from the historical basis. Next slide. So when the people start, from my literature search, and people started talking about the new DSM, way back when they first started talking about the 5, they're like, this is going to be a brand new approach, brand new paradigm shift. They had all these high hopes. They got tons and tons of feedback, apparently. This is one of the new, in the internet age, they got lots of feedback about how to change it and what the complaints and concerns were, until now that the statement was, this is going to be a conservative document that will have a minimal impact on diagnostic rates. My claim is, who knows? Where, in the DSM past changes, you don't know for a couple years exactly what impact the changes you're going to have are going to be until it's out there for a little bit. Insurance jumps in, and we as clinicians learn how to use it better. You just don't know. I mean, we can make all these guesses, but we just don't know. Next slide. So I want to just run really fast through these slides, just to let you know that there's more to it than just autism. Some other non-ASD changes. I think if I did a poll and said how many people watch Hoarding on whatever channel it is on the cable, you probably have watched that. So maybe that would spur this as its own new mental disorder. You can see there's a couple other ones that are actually getting their own diagnostic label or their own label within another diagnostic category, like binge eating is now being separated out in terms of the eating disorders. Next slide. The ones that are more thorny that people talk about that are not ASD related is they're actually, you might have read or will read some of this stuff that's happening, even more so than the ASD changes. Grieving is now counted as its own mental disorder. People are really worried about that. So the bereavement exclusion from depression is being removed, which means that if you have a significant reaction to the death of someone close to you, for example, you can actually be diagnosed with a medical disorder, which people are worried about over-pathologizing depression. Same thing true in bipolar, similar to ASD. There's been this explosion of diagnoses, 40 times the rate in bipolar with the DSM-4 They really wanted to slow that down and actually back up with the literature. But one of the problems was, apparently, they've settled on what's called disruptive mood dysregulation disorder, DMDD, and people are worried that that's going to pathologize basically temper tantrums that kids may have. This is mostly in smaller children. So ASD, the point here is ASD is not alone in terms of the questions people are asking with regard to the DSM-5. Next slide. All right, so let's jump right into the changes. A lot of these you have already heard about, so they might not be new to you. So what I want to do is get to the slides that talk about the actual wording in the DSM-5, and you guys are going to react to that a certain way, I think. So one of the big changes, as you know, is that PDB as a diagnosis is now, as overarching category, is now being changed to autism spectrum disorders. For me, as a clinician, I'll be really clear where my bias is like, this is a great one, because how many times have I sat there with a family and tried to explain, well, you know, I'm diagnosing your son with autism. It's not, you know, really we call it pervasive developmental disorders. I don't know why they call it that category, but it's really autism. So away with all that, we can actually call it what it is, which is an autism spectrum disorder. But the flip side of that is this whole, we're getting rid of the diagnoses inside of it. So autistic disorder, Asperger's, PDNOS, CDD, and RES are going to be removed. It's just going to be a single category. Next slide. So the Asperger one, I know, has reared its head many times with regard to, you know, in terms of the feedback that the committee apparently has gotten, was that there's a lot of folks that don't like the fact that Asperger's is being removed as its own diagnostic label. Actually, I think this created some debate and intense discussion on the committee itself, with some people believing more strongly that Asperger's should remain and others not. And there's many reasons. You know, there's studies that I'm not going to go into that actually show why Asperger's should be removed as its own diagnosis and instead be considered just part of the autism spectrum. But part of it is the scientific validity behind it, the lack of specificity and sensitivity separating the diagnoses, historical information. I think this last point, site-specific, let me just talk really quick. One of the most recent studies that we were involved with here, even with the Sameness project that Kathy Lord published recently, had to do with when you equalize certain things, the only thing that determined across sites, regardless of phenotypic similarity in terms of an actual diagnosis the person got, was the place they went. So even though Joey might have went to our site and got autism, he might have went to Yale and gotten Asperger's, might have went to Emory and gotten PDD-NOS. So in terms of the categorical distinctions from the phenotypic side, there didn't seem to make a whole lot of sense supporting them. And that's just one piece of information. I think another one of my favorite studies was when they actually went by the book and looked at Asperger's original cases. None of his original cases would have met the criteria for Asperger's disorder. They would have met for autistic disorder. That, for me, was kind of the coup de grace. Next slide. So another big change is that the 3 domains of communication, social, and repetitive behaviors are collapsing down to 2 domains. So yeah, I always talk about this with folks. You know, if you define communication, it means you have a sender and a receiver, which by its very definition is social. So why in the DSM-4 did we maybe arbitrarily separate out communication from social? Because we meant more than just language. We meant communication and social. So a lot of the research, factor analysis, and other types of studies have shown that, well, maybe we shouldn't separate out social from communication. There really is one dimension of social communication. So that is one of the changes that's being reflected in the new DSM, where social and communication are being collapsed into one, and repetitive behaviors is actually going to remain as its own. And just to give you guys a kind of a heads up, repetitive behaviors is not only remaining as one, but you know, a lot of the most recent research is actually showing that it shouldn't be even considered a stepchild to social communication. It should be thought of as completely equal in terms of the presentation of autism. This is based on some of the work that Sally Rogers is coming out with early intervention type of work, where they're showing the repetitive behaviors are actually present from day one and might actually, we don't know how much of an impact they have and how closely related they are to the social communication deficits. Next slide, please. So just real quick, I wanted to run through, I know this is boring for a lot of people. I tend to be a geek, so I like these approaches. But a factor analytic approach, so this is from Fraser et al. In 2012 off of the IAN, the Interactive Autism Network, where he analyzed symptoms of 14,000 sibling pairs, 8,000 which had ASD and 5,000 not. He used a hybrid model to say, okay, what fit them best, the 2-model version of the DSM-5 or the 3-model version of the DSM-4? And what he found, or she, I don't know which one it is, actually found that the 2-model, the DSM-5 model actually fit the data much better than the 3-one did. Next one, please. Another replication of that in a different way was by Manny, Charman, and Skuse in 2012, where they showed again that the DSM-5 model in their particular sample was much stronger than DSM-4 TR. The reason I put this up here in addition to that was it was actually improved even more when they started tweaking certain things. And I think this is a really important point to make about all the studies we've all been reading about, is the DSM-5 better, how many people are going to get hurt, who's going to be left out, and this is something that Sweeto in one of her talks really made it clear too, is that there's lots of weaknesses in terms of those studies, because a lot of them have been using criteria that were initial draft criteria that weren't the final criteria that DSM-5 is now based on. And as you'd want to happen when those studies came out, things were tweaked with the DSM-5 criteria, is what I understand, such that it makes it even better. And this is a good example of that when his particular model, or her model, when they actually removed certain items or added other ones in, the model actually did even better. And I think this drove it a lot too, with the scale measuring sensory abnormalities was loaded in, as added to it and loaded onto the repetitive behavior model, which I think the RRB factor, which actually made a difference in terms of how the DSM-5 is being conceptualized as well. So go ahead and change. So other changes in the DSM-5 or higher order social impairments, you're going to see when we go through their criteria, they really, by they I mean the working group, really tried, I think, to capture higher order social impairments. Another difference, I'll go ahead and click the slide for me and a box will pop up. So here's the criteria for the DSM-4. The reason I do this is to really show you how the wording changes where they really try to capture this. So the DSM-4 checklist says failure to develop peer relationships. Now, again, look how it's worded, failure to develop peer relationships and abnormal social play. The reason I point that out is I think we did a big workshop last week with clinicians comparing the DSM-4 to the DSM-5. The one comment that every clinician kind of made was that the DSM-4 starts to feel like a checklist where you just like check things off and it's all or nothing and see if they fit into it, where the DSM-5 has a whole different approach, and it might be subtle, but it's definitely a real thing where the way it's worded makes you at least emphasize your own clinical judgment, I think, to a much greater degree. The DSM-5 recommendations include higher order impairments, and the way it's worded is difficulties adjusting behavior to suit different social contexts, much different than the DSM-4 wording, failure to develop peer relationships. And that's a good example, I think, of how the wording is much different across the two. Next slide, please. So another big change is relaxing the criteria for onset. So the DSM-4 requires that symptoms begin prior to the age of 3. This is huge, too, for the DSM-5 because they require that symptoms begin in early childhood still, but then they have a caveat that symptoms may not be fully manifest until social demands exceed capacity. So trying to capture, I think, those kids who, even though their current presentation is such that the gap has been big enough that you now recognize those changes, and then you go back by history and say, oh, yeah, they're already there, but the gap might not have been as big then. Next slide, please. Okay, another big change, and by the way, all of these I can't minimize how major these changes are. The first one is that there are, in the old DSM-4, you had to meet 1 in the category of repetitive behaviors, and now you have to meet 2 in the category of repetitive behaviors. Another common theme that you're going to hear is that what the DSM-5, I think the working group was trying to do is maintain the same level of sensitivity with regard to capturing everybody who might even sniff of autism, but improve the specificity. So get rid of the folks that seem like they do have autism but don't. And this is one of those changes where we actually have to meet 2 in the criteria of repetitive behaviors. Another big change is it actually states, you'll see as we do the text, that it can be by history or current. So if you have a 25-year-old coming to you and they say, I've been through tons of therapy and I'm doing much better now, if you can document by history that they showed a certain set of symptoms, then it's possible that they'll still be in the DSM-5. Another big change is the sensory. They've actually added a sensory criteria in the repetitive behavior section, and that has never been in there before, and that's going to kind of change the way we approach that entire section. Then we'll run through some of the specifiers that they put at the end and how we try to get this dimensional feel for each patient that might be diagnosed with autism by the use of their specifiers. I'm talking really fast, so we have time for questions. I'm sure there'll be a bunch at the end. I just want to put this up here. This is the working group. You can see they started in 2007. I don't know this for a fact, but I think the reason there's parentheses around Volkmer's is he's one of the people who dropped off early on because of some disagreements with the group. But you can see it's a fantastic group of folks who know a lot about autism, obviously. Next slide. Okay, this is the actual criteria as I have written it down in my last, or what I understand to be the latest draft of the DSM-5. I cannot, this is my caveat or my little thing at the end of a commercial. I could not guarantee that this is what's going to be in the published text. As a matter of fact, I can't do that for copyright privileges, but this is what I understand to be the best shot I have at whatever text is going to be in there. So the significant stuff here is this is the first category. You have to meet an A, B, C, D, and E, just like in the DSM-4. This is the social communication part. And notice the first paragraph, and then you have, it's not that you have to meet 2 out of the however many they were in the DSM-4. They have to meet all of these, but they're written much differently, you can see. So they have to have persistent deficits in social communication across multiple contexts. So it can't just be, you know, in Mrs. Jones's class at school. It has to be across multiple contexts. And you also notice in there it says currently or by history. So again, that's where that part comes in, that they have to show these things, that not just now, but they can have shown them by history. You can still diagnose them. So the first one is deficits in social emotional reciprocity. Go ahead and click the slide. Okay, so what this means, what I liked about the way that the DSM-5 seems to be written is that they describe deficits in social emotional reciprocity, and they really try to anchor you, I think, with these examples. And they're not exhaustive, but you know, in reading these, it's like, okay, here's a high-functioning kind of notion of it, all the way down to a much more severe presentation. So they're giving you some anchors by which to think about these different areas. So the social emotional reciprocity, which may range from abnormal social approach, failure of normal back-and-forth conversation. So notice we have right off the bat both social and communication in there. Reduced sharing of interests, emotions, affect, and then the other side of the anchor is failure to initiate or respond to social interactions. Next slide. And click it again. So deficits in nonverbal communication used for social interaction, so ranging, for example, poorly integrated verbal and nonverbal. So this isn't just you don't make eye contact. It's the kids who also don't make eye contact and integrate that with the right gesture or vocalization. To abnormalities in eye contact, and again, it's not a lack of eye contact, it's just poor socially modulated eye contact, and body language or deficits in understanding and use of gestures. So here's another addition, is it's not just doing gestures, it's actually understanding gestures, total lack of facial expressions, or a total lack of nonverbal communication. Go ahead and click. Deficits in developing, maintaining, or understanding relationships. Again, just a brand new way of saying that. So it's not a failure to develop peer relations at all. It's deficits in being able to develop, maintain. How many of us have read the DSM-4 and said, okay, what's the difference between a marked, you know, impairment versus a lack of, versus, you know, how do I judge that? Well, this gives us a lot more degrees of freedom. They're just saying you need to have deficits, and then they anchor us with a range. Difficulties in adjusting behavior, to difficulties sharing imaginative play, there's your play one, or in making friends, to the other side of the anchor, which is an absence of interest in peers. So anyone coming to you now in the future in the DSM-5 is going to have to meet every single one of those to some extent, by history or currently. Next slide. So here's the second major category. So we have 2 now. The first one was social communication. Now we have repetitive behaviors. Restricted repetitive patterns of behaviors manifested by at least 2 of the following. So you don't have to do all of these like the first category. You only have to do 2. But again, it's currently or by history. And again, they put the caveat, examples are illustrative, not exhaustive. So go ahead and click the first one, please. All right, so this is really, the first one is really those repetitive behaviors, the RSMs, you know, use of objects or speech. What's also interesting here is notice that within the repetitive behavior section, we now have a language component, which is new. And this is, again, a lot of the research has shown that things like delayed and immediate echolalia are actually repetitive behaviors. That's where they're loading on, and that's where you're seeing them in here. So they're no longer in the communication part with echoing. They're actually here in the repetitive behavior part, which is a big shift for us. So simple motor stereotypies, lighting up toys, flipping plates, delayed and immediate echolalia, scripting, basically. Next one. So this one really gets at the insistence on sameness. And if you follow the repetitive behavior literature, it really has broken it down into 2, sometimes 3 factors. The repetitive sensory motor movements, which we just did. Oh, go back to that one if you can. Sorry. There we go. Or repetitive sensory motor movements, and then there's this insistence on sameness. And then sometimes a third factor flows out, which is the really circumscribed interest, which is going to be the next one. But this is insistence on sameness. These are the kids who, you know, can't drive the same way. They have to drive the same way to school every time. They think rigidly you can only play Monopoly a certain way. They get disturbed if you move their knick-knack 3 inches to the left. That's what this one is kind of focusing on. Go ahead and hit the next one. Where this one is, the third one is more the kids who have those circumscribed interests. But it's more than that, because this is also the unusual attachment kids. So it's both attachment and interest is the way I'm reading this. So you have the strong attachment or preoccupation with an unusual object like the spoons or vacuum cleaners, or excessively circumscribed or perceptive interests like me in Star Wars, basically. Next one. And this is the new one. So now we are adding sensory into here. And I want you to notice it's not just one aspect of sensory, meaning it's not just sensory seeking or sensory defensiveness, it's really both. So they have to have hypo or hyper reactivity to sensory input or unusual interest in a sensory aspect of their environment, pain or temperature, adverse response, some kids who don't cry whenever they see a guy's beard, textures, excessive smelling, licking of things, the visual inspection, those all go into this particular section. So those are the 4 that you have to have for the repetitive behaviors. You don't need all 4, you only need 2. You can have 3, you can have 4, but you only need 2 of those. Again, this is a huge shift because by making it 2, it has increased the specificity of this diagnosis, I think. At least the research shows. Okay, next one. Okay, so here's the C and the D. I think we've already gone over symptoms must be present in early developmental period, but it's then the caveat that it may not become fully manifest until the social demands exceed. So we're trying to capture that, if they come to you and the gap isn't big enough, we're still going to be able to grab them when they get older. And of course, like every other DSM diagnosis, that has to cause impairment somewhere. It can't just be quirky professor down the hallway. Next one, please. Who may be impaired, who knows. E, these disturbances are not better explained by intellectual disability or global development. What I love about this particular paragraph, the way I understand it, they actually teach, because this says intellectual disabilities and autism spectrum frequently co-occur, if you didn't know that, and to make comorbid diagnoses of autism spectrum disorder and intellectual disability, social communication should be below that expected for a general developmental level. The notion here, those of us who do the dual diagnoses and try to avoid diagnostic overshadowing, you want to make sure if you have a child with intellectual disability that whatever developmental level is, that whatever you're seeing social communication-wise must be below that. Next one. They actually grandfather, is my understanding. They're going to have this in the text where individuals meeting DSM-4 criteria for autistic disorder Asperger will now meet criteria for autism spectrum. But here's the next theme you're going to hear through all the studies I'll run through, is that it's the PDD-NOS ones that might be more questionable. So individuals diagnosed with PDD-NOS who do not meet criteria for ASD, currently or by history, but have the deficits in social communication, there's another whole new disorder that is in the DSM-5 called social communication disorder. It's kind of like the pragmatic language disorder. That's what they should be evaluated for. And I'm sure people are going to have questions about this because this is where people are really going to get concerned. It's like, well, that's a new diagnosis. Does that mean if I'm diagnosed with PDD-NOS, which is autism, now I have to go get services? Or will I get services for this new disorder? And when we had our conference last week, this is where a lot of questions from the state people and from the providers actually were. It's like, okay, we get this. It makes sense. But what does this mean in the real world? How are we going to get these services for these kids who are now getting them, or will they? So, next slide. Okay, so what I really like about this, and by the way, I don't know enough about this to know how it's going to really work, but I have a fantasy about it. So the DSM-5, they're going to have these specifiers. So let's say it's 299 is still the number. I don't know if that's true, but let's assume it is. Then you put these specifiers at the end of it to say, is it with or without regression? When was the age of first concern? Is there an intellectual impairment also associated with it? Is verbal or nonverbal going to make a difference in it? Do they have a structural language impairment? Is there some medical genetic, is Rett syndrome involved, Fragile X involved? Is there some other mental or behavioral diagnosis involved? But then there's a severity index, which I'm going to talk about for a few seconds too. But I guess I don't know how this is going to work, but the neat thing is it's moving to this whole more dimensional approach that even though you have autism spectrum disorder, this will allow you to do a lot more descriptive, give you a lot more descriptive information in the numbers at least with regard to the pattern or profile that this particular patient might have. Next one, please. So the concerns that people have about this, and again, I'm sure you guys have heard this yourself, is some patients might not get services. Like we were asked at this conference last week 1,000 times, does that mean I need to come back through and get reevaluated? I'm like, no, are you kidding? My wait list is long enough. I don't need to reevaluate everybody. But people have the legitimate question that if it's PDD-NOS, do I need to come back then to make sure it's still this or this other disorder? There's some concerns that people have about the research data not being able to bridge over from the past diagnosis, DSM-4, to this one. Do clinicians need retraining on this, and do patients need to be re-diagnosed? Next slide, please. I love this, by the way. So this is the part about the DSM-5 that I've heard about that I really, really like in the talks that I've heard. And I've already started using this. So instead, how many times has you as a clinician heard the patient say, okay, my child has autism, how bad is it? How severe is it? Give me a number on a scale of 1 to 10. And you know as well as I do, you can't do that because they might be, they're so heterogeneous and there's so many variable dimensions across social communication and repetitive behaviors and all the comorbidities that determine how severe something is, that you just can't put a metric to it. It's really, really hard. So what the DSM-5 is moving to is instead this, how much support do they need? And I love that. It's much more of a functional kind of feel. It's like, okay, instead of saying it's a 7 out of 10 in terms of severity, it's like, well, how much, regardless of the profile, how much help does Joey need at home? And they actually break it out by the 2 different areas of the main ones of social communication, fixated interest, repetitive behaviors. What I put on there is just some examples. That's not exhaustive either, but just give you some sense of how they're anchoring those. And they'll have at least the 3 different areas that requires very substantial, substantial support, and then there's, of course, a no support as well. That gives you some sense of how what examples they're using in there about what does it mean to need support for social communication. If they have severe deficits and very limited initiation, they're going to need very substantial supports. But just supports they can actually do some initiating with some clearly atypical, maybe some decreased social interest, but they do better than they do if they have the severe one. So for me, it's just a kind of a paradigm shift and a better way of thinking about severity level. Next one, please. Okay, so I'm not going to be exhaustive like on each one of these studies. I just want to give you a sense. I did a literature search, and here are some of the major ones that I came across. And I think what you'll see, at least I did, is kind of a pattern starting to emerge, which I'll prep you on. The first one is that a lot of these studies used different methods to gather this information. A lot of it was using criteria that were not the latest draft of the DSM-5 because they couldn't because they weren't out by then. But the other is like who's going to get excluded possibly. So go ahead and do the first one, please. So McPartland et al. 2012 used the DSM-4 field trial checklist items and then assigned them to DSM-5 on 933 participants. And what they found is that the DSM-5, when they did it that way, performed quite poorly, meaning that how it was put as the DSM-4 checklist items were put on the DSM-5 checklist items that they had. And it actually missed, they said, 39% of the cases. At the very bottom note there, it missed primarily Asperger's and PDNOS is what it seemed like. Next one, please. Again. There you go. Matson et al. 2012 on 2,721 toddlers at risk. They applied both DSM-4 and DSM-5. The DSM-5 resulted in about almost half of the toddlers being diagnosed with ASD compared to those in the DSM-4. But already there are problems that other people have mentioned with this particular study. One was how the errors were counted only against the DSM-5. A single clinician made both diagnoses, which could have created a bias based on retrospective chart review. And all the original questions didn't include necessarily DSM-5 type checklist items. So these were some of the earlier studies that definitely had some methodological issues, but they were starting to show that, hey, it's not perfect yet, so we need to do a little bit more work. Next one, please. So Mattila, 2011, an even earlier one, used a very early draft of the criteria in Finland with 5,484 8-year-olds. They only looked at PDD as an entire category. What they found, if you drop down to the bottom point, is that when criteria are more similar to the DSM-5, it went from 46% all the way to 96%. So when they went back and looked using more current DSM-5, it made a huge difference in how well the draft criteria were doing. But if you look at the fourth point down, again, the people who seem to be missing were the Asperger's and the high-functioning subjects, again, according to that one, until they added some differences into it, including what you see listed, the routines and rituals versus routines and rituals, included sensory items, which really improved the results of that particular study. Next one, please. We already talked about this one. This is the Fraser et al. Study again, which showed that it had improved specificity over the DSM-4. Next one. So we are getting mixed results. The interesting thing about this one was they did a chart review of 131 children who diagnosed with autistic disorder or PDNOS. So 63% of those met the DSM-5. Again, here's the common theme, though. About 81% of those that were diagnosed with autistic disorder remain that way, but only 17% in this particular study of those with PDNOS. So That's that specificity question again. PDD-NOS, as we know as clinicians, that's the ones where we sometimes lump the iffy kids in. Well, this is going to start possibly making them less iffy. Next one, please. Gibbs in 2012, another 132 sample of children. Again, 50% of the PDD-NOS would not meet in the DSM-5. Next one. So Sweeto in 2012, she had put out a paper just highlighting to folks that there are difficulties with the methodology associated with those, not only in how the actual, what criteria they use or the approach that they used, whether it's historical versus current ratings, but also the fact that those are good things, though, because those studies actually helped tweak the addition or taking out of certain items, or even the word. What I was impressed with when I was watching the DSM-5 criteria change is even just the tweaking of certain words. Like I would compare one to another, like a single word might have changed, and it really paid a lot of attention, I think, in terms of how they're going to say everything that they had to say in there. Next one, please. One of my favorite ones came out recently by Matty Herrington in 2012, where they looked at over 4,000 kids with PDD and 690 without out of the SSC data set, the Sameness data set. And the DSM-5 criteria were assigned to particular items on the ADOS and the ADI, and what they found is those DSM-5 items then accounted for about 91% of the people being identified. What they showed is that it's remained as sensitive, but again with greater specificity, and again the ones, as you would suspect, are the Asperger's and the PDD-NOS kids are the ones that are more subject to the specificity. Next one, please. I'm going to try to go a little bit faster. I'm already talking really fast. Again, I want to make sure you guys have enough time. I want to end up about 10 till if I can. So the DSM-5 field trial that was published recently, so 2 sites were involved in it, 63 school-aged children. I couldn't find the actual article, believe it or not, but what I came across in a summary of it was, so I apologize, I don't have the actual number. The main purpose of it was to find the reliability across clinicians, which they found the test-retest reliability was very good. And all the comment had most who met DSM-4 met DSM-5, but I don't know what most means. I don't know what the actual number is. And again, the common theme, those that didn't either had Asperger's and PDD-NOS were the main ones. So, next slide, please. Okay, so I was at this, Sweeto had put on a talk, and a lot of the DSM-5 working committee were there at IMFAR. I think it was the best attended session I've ever been at IMFAR. There must have been like 5,000 people in that room, it seemed like. And what she did, she went through at the time kind of where they were at with the DSM-5 and kind of the different issues they were dealing with. And I'm not going to redo her talk, obviously, but these are from the notes that I took down. Is the big point was that it was almost hurtful in some ways in the sense that from some of the stuff that got leaked out and the articles that came out with the New York Times, it's almost like people were accusing the DSM-5 work group of trying to exclude or not do things for the patients they should be, where, again, the folks, at least the ones that I've talked to, were very much like, no, how can we not only take care of the patients that we have and do the right thing, but also move the field forward in terms of how we think about autism and how we're approaching the diagnosis. So there's just a whole bunch. Wall Street then came out and said, chill out on this. You really, if you go dive down into the depths of the new wording, you can see how with access to services, for example, many Hispanics and blacks have shown to have less access to service, so they have a later age of diagnosis. Well, now by including some of the wording that we did, you can actually capture them with the new verbiage. Same thing with possibly women having a different type of presentation at certain ages. There's things like with the specifiers where the etiological kind of, if we know the genes, it can be removed or whatever other type of other etiology might be involved. Next slide, please. Over 5,000 people, though, still, if, for example, the Asperger's Association had signed a petition saying, don't do this. And actually at the session, I'll never forget the plea by a person with Asperger's who stood up and said, I'm one of those people, don't do this, please don't do this. And my gosh, I can't even imagine how you can respond to something like that. And one of my favorite was, and I've read a couple articles of this now, where Tom Abenanti, I don't know how to pronounce his name, in New York said, okay, we're just going to pass a bill where you can't change. We're not going to listen to DSM-5. We're just not going to do it, which I just love. I'd love to see how that might work out for him in New York. Next slide, please. Also kind of tried to explain to the entire group then why Asperger's was out and kind of what we went through here, some of the new approach. Next slide. But again, the notion is support rather than severity, which we went through, and the do no harm. And my sense of it, when we talked at this recent conference, is really helpful talking to a bunch of clinicians working through this, was you're still going to have, we're always going to talk about that Asperger's profile, but it's going to be a profile with perhaps these specifiers or whatever within the autism spectrum disorder. So it's not like it's going to disappear. It's just not going to be called out as its own ideologically clear, distinct diagnostic category, which I think most of us, or a lot of us, I shouldn't say that because there's a big debate in the field, but a lot of us have already been kind of moving to that. And one of the big reasons why you perhaps see the changes that you have with including 2 in the repetitive behaviors and these other things is they really want to start separating out, and just because someone might be quirky or have a broader autism phenotype, they don't have autism, so they shouldn't be diagnosed with something like PDD-NOS or high-functioning Asperger's. So a lot of the changes, I think, are designed to create perhaps a much more careful, even a shrinking of the diagnostic prevalence because of that, with these different becoming more specific. Next slide, please. So before I go into this slide, I just wanted to mention one thing that I found very instructive. Like I said, we had this workshop where we had a bunch of clinicians we had 2 cases that we went through, and we had them diagnosed by the DSM-4 and the DSM-5 and just talk through. And I want to at least give you guys a sense of that, because that helped me a lot with my, I think, my appreciation for the DSM-5. And when we talked through it as a group, the main thing that we all talked about, and you can reflect on this yourself with the symptoms or how it's written that we had put up here for you, is it's a subtle change in how you approach a diagnosis. It really was. What we found is that sometimes with the DSM-4, we felt like we had to shoehorn people in. It's like you as a clinician said, yep, that guy has autism, and then you go through the checklist and, well, failure, market, I'm not sure, let's give him that one. This, the way it's written, and the deficits in, and having to meet all of them and give you the range, really, I think, gives you more degrees of freedom as a clinician to exercise your clinical judgment in a sound and ethical way that you can then apply to the patients. And what we found is all the clinicians in the room raised their hand that they actually liked the DSM-5 when we approached it that way rather than the DSM-4, because it has a whole different feel to it. What I don't know is all these other concerns that we're talking about with, well, what's going to happen to these other folks, though? What's going to happen to the PDD-NOS that we would have diagnosed? And we've all done that. You've all seen the kid. If if I had to do a show of hands, say how many people you've seen a kid doesn't show repetitive behaviors currently, or maybe not even by history, but they have those core social communication problems that you know in your mind that we used to define as autism, that you give them PDD-NOS as a diagnosis. What we're doing now is saying, no, all the new research is showing that repetitive behaviors are equal in standing to the social communication deficits. Then I think the new DSM-5 is supporting that in not only having its own equal category to the social communication, but also requiring 2 to meet there. But it might not be as hard as you think because of the sensory and some of the verbal stuff we'll load into it. So the question is, what happens to all of these non-repetitive behavior individuals? And this is the inclusion of this new social communication disorder. Go ahead. Next slide. So this is how the DSM-4 versus the DSM-5 is kind of working out with language disorders. So you can see there are some pretty big changes, and I cannot talk about this stuff because I did not research it greatly. I'm not a speech and language pathologist. So you can see that they have the structural language stuff on the DSM-4, but now they're going to have language disorders, including specific language impairment and late language emergence. But now we have this social pragmatic communication disorders, of which social communication disorder is going to be one of them. And then there's a whole range of speech disorders that they're going to have in there. Next one, please. From my understanding. And again, I'm not going to go into depth in this, but this is how I understand the criteria for the social pragmatic communication disorder. It is much different, by the way, than I shouldn't say that. I don't know that. There's pragmatic language disorders. Talking to my speech language pathologist, when they read this, their reaction was, this feels very different. Because if you read even in letter A there's so much more about the social piece of it. Not only that, but you have the nonverbal piece in it, which is totally different in the past. So persistent difficulties in pragmatic social uses of verbal and nonverbal communication, which takes it, it takes out of the realm of a language disorder and puts it into a communication disorder, which is a different way of thinking about what used to be, at least a lot of language therapists in my understanding thought of as a pragmatic language disorder. This isn't just a pragmatic language disorder. This is talking about pragmatic communication. So it really has broadened out this category into something brand new, which none of the states in terms of eligibility, schools or insurance have I don't think know what to do with yet. And I think that might be one of the areas of legitimate concerns, like, okay, we take these PDD kids out, PDD-NOS kids out, we put them in here, but we don't have any support services set up. Can you have the next slide, please? They do have a rule out for autism spectrum. They talk about being in early childhood, so you can't catch it when you're 5 years old. And of course, it has to show an impairment as well. Next one, please. All right, I did good. I wanted to end with enough time because when we gave this talk at the conference, there were a ton of questions, and I'd be happy with other folks who may be as familiar with this. Again, this isn't out yet, so my role was just to present what I've heard and what I've known in the studies and kind of what we did at the conference and the questions that we had. But if there's other folks on this call that know as much or more than me about the DSM-5 and what's coming out, I'm sure we'll be happy to entertain that too. But I want to give the chance for questions, if that's okay, Alex.
Yes, absolutely. And I've also added Susan Sweeto, who will be joining us as well. I don't know if she can talk just yet.
There. She's unmuted.
Hi.
So the neat part was I got to present this because I'm kind of objective. I wasn't on the working group, so it's so nice to have Susan Sweeto here too, who was on the work group, who can either correct everything I said or
oh my gosh, no, I just want to thank you for everything you said. I was listening the whole time with some trepidation, but I now want you to go out and tell everybody what you just told this group because you
and I really was unbiased, to tell you the truth, because I'm not sure either. But again, what impressed me was when we did this as a workshop, it seemed to we loved it. But I mean, it's just my own bias, but it really did kind of fit what I kind of was already doing anyway. So.
And I think there is some, the only thing I would add is the increasing tension about impact on prevalence rates, number one, and number two, denial of services. And that's probably where obviously everybody on the work group was concerned that we didn't want to do any harm to individuals with the diagnosis. But on the same hand, I think it's been fairly frustrating, the lack of specificity from some of the CDC studies in terms of using educational reports and word counts when ADHD was exclusionary with autism. And if you had a child with a severe ADHD, they actually met all the autism criteria just on the basis of their ADHD symptoms. And yet people might have used the PDD-NOS category to give them that diagnosis. And one of the things that I urge everybody to do is to go back and look at DSM-4 definition of PDD-NOS, because those are the subjects that are going to be moving categories. And the reason is because DSM-4 included in PDD-NOS 3 groups that most of us would agree didn't belong in an autism spectrum. One was individuals with communication only. The second was individuals with RRBs only, also might have been diagnosed with stereotypic movement disorder. And the third was this wastebasket of subthreshold symptoms in either domain. So you really could have an individual with very mild, what we might even call the broader autism phenotype, who could meet the DSM-4 criteria for PDD-NOS. If those were the ones that were being missed in the Finland study and some of the others, I don't think any of us would be upset. If, on the other hand, individuals who have impairments from social communication deficits and the presence of RRBs get missed, we'll be sad. So, as Steve had pointed out, we included now for the first time by history as sufficient to make the diagnosis, and you're probably going to need to use that most often in that area of restricted interest and repetitive behaviors, because they can either be trained out with early interventions or masked, or sometimes they actually have outgrown them. But if they've had them at any point during development, then they would still qualify for a diagnosis. I almost talked as fast as you did, Steve.
Well, I see some of the questions is someone had asked if ADHD can be comorbid with ASD, and it is my understanding that with the DSM-5 we can diagnose ADHD now comorbid with ASD. Is that correct, Sue?
Yes, absolutely, and are encouraged to, just as you're encouraged to use co-occurring diagnoses of intellectual disability or intellectual developmental disorder and ASD.
And I see someone commenting on how fast I talked. I'm really sorry, but I wanted to get through the slides so you guys can ask questions.
Hey, we can listen that fast.
Other questions that folks might have?
Yeah, so we have a lot of questions here. There was one from Kamina Ballard. Just curious if you think the CDC's prevalence of ASD will change as a result of the DSM, especially as it pertains to their 1 in 50 rate in school children.
And I wanted to echo, and Sue can jump on this too. I mean, I hesitate. I am resisting actually using the new numbers now. It's great to write those in a grant, to show how much you need some money. It's great for press, but I don't know if I reflect other people's concerns out there with these prevalence rates, because the more, we have right next to us at WashU, we have one of the CDC sites, and it is based on chart review. A lot of it's based on what people write in those charts, so if you're more aware of it, or if insurance now covers it, it can change things. If you watch
it's even worse than that, in my humble opinion, because it isn't medical record reviews. For at least half of the sites, it's school records only, and they're doing it from an IPA where you're driving the words used to justify services required. So I think the prevalence rates, I would just 100% echo what Steve says, that we're not sure what they are. At the IACC meeting last week or the week before, HRSA presented their data about 1 in 50 overall, but 1 in 33 boys. That gets to the point where you start saying, what's going on, and not in a way that we've had a change in prevalence, but we're lumping things in together. So I think the short answer is yes, prevalence rates will change, but I'm not sure how much or in what ways, and we'll have to just wait and see. We're hoping to continue to educate about the fact that social communication disorder was specifically not part of the autism spectrum disorder, because inklings from the CDC are they've already talked about starting to count them as a single unit, and then then the prevalence will actually go up.
So do you have a sense about those specifiers? Like, are we going to list all of them, or is it going to create like this profile? Or
yeah, we hope that they'll be able to create a profile, and without breaking the embargo, because I'm so mad at them, I don't care about the embargo. Somehow in the last editing after we had gotten page proofs, it looks like the with or without loss of established skills and age of first concern, which we had sort of melded into age and type of symptom onset to try and avoid having quite so many specifiers. Those may actually be out. But the hope was that this very broad spectrum would be described, just as you said, Steve, to the individual level with a nice, rich description of strengths and weaknesses, and that we could include those in research reports so that as you read it, you'd have a sense by looking at maybe a supplemental demographic table of just who's being studied. Is this the same 5% of folks with ASD who are high enough functioning to get into a scanner, or is this a broader representation of the patient population?
Alex, do you have any other questions? Or?
We have time for a couple more questions. Will there be a requirement that all of the clinical specifiers be stated, or can they just be left blank or unknown?
They don't have to be used at all. So you could just, the only diagnostic requirement is that 299.5 or whatever the new code is, and I think it's actually staying the same. So the diagnosis of autism spectrum disorder is plenty. In research studies, I think one of the things the ATN can help push the field forward is encouraging folks to use the specifiers, and particularly the severity of each of the two domains, because we don't now know how those track together except by going back and looking at ADOS scores or ADIR interviews.
I can try to answer two of the other questions I see on here too. The first is, will insurance companies require re-diagnosis? I think that's really, what we found here in Missouri, a state-by-state thing. Who knows? With insurance companies, probably, I would think, but it would put such a load on all of our systems at the schools, the state, and our clinics that we don't want it. And I know our state is moving against that. They're like, no, they'd rather grandfather everyone in. They can't keep up the way it is. So,
and that was actually the very specific purpose of that note that Steve read, in terms of if you met in DSM-4, you've still got it in DSM-5. No need for re-diagnosis.
Right. I think that there was one before that about the history. One thing that I was hoping for in the DSM-5 was what a lot of us as clinicians deal with, which is these kids who do improve enough through treatment or therapy or just by natural development where they don't meet necessarily behavioral criteria as clearly. So how do you know, we do have it by history, saying that we can still diagnose them, but I was kind of hoping for some like specifier that says in remission or something to capture that currently they're not showing symptoms, but they did by history, and how can we capture that either through a diagnostic code or otherwise? So,
right.
Do you have a comment on that too?
Yeah, I think the one way that could be done is, again, by use of the severity specifiers. So you give them the diagnosis of ASD, but on both severity specifiers it might be very mild, or you could even say add in the note. And we talked about having in remission or not, but the number of cases was so few at this point in time that it was felt that it was better to leave it as a lifetime diagnosis.
And is that repetitive behavior disorder still in DSM, so we can capture the RRB kids that don't have social communication deficit?
Yes, stereotypic movement disorder, or stereotypic,
right.
Stereotypic movement disorder is what it's called, but it does include this broader group.
Right. I got like 2:59. Alex, is there any other questions you want us to try to answer?
One last question. It says sometimes reevaluation is indicated to update a child's status and level of functioning. It seems that some families may be reluctant to undergo reevaluation in case they lose an ASD diagnosis. Any thoughts about how to address this concern?
This came out our workshop too. If you think about who requires that, it's primarily either eligibility determinations, like through the state they might require a re-up, or a school, like an IEP, might require the re-up. A lot of us as clinicians, we don't necessarily have folks come in to re-diagnose them. We come in to have them come in just to check up and see how we can help. So I would respond, at least I did from our clinic side, that we don't require folks come in every 2 years or 3 years and get re-diagnosed. It's only if the parents want to, so we can help. So it's really not even a medical diagnostic issue. It's more of an eligibility issue for either the school or the states, how they're going to do that. Sue, do you have any other?
Yeah, no, I